حضراتكم في السيرجيكال جراند راوند رقم 13 لقسم الجراحه، وبنرحب باستاذ دكتور ريم الحربي، استاذ مساعد جراحه الشرج القانوني وعميد كليه الطب جامعه الاميره نور بنت عبد الرحمن في المملكه العربيه السعوديه. السبونسرز بتوع المؤتمر النهارده شركه كاسينو وشركه تاتش ستون وشركه بيوراميد فرانكو. دكتور احمد هيقدم لنا توب قصيره كده على البرودكت شركه كاسينو.
السلام عليكم. السلام عليكم، ازي حضراتكم؟ بشكر دكتور سامر على الدعوه الكريمه والساده الاساتذه، وبرحب بدكتور ريم. ان شاء الله النهارده هنتكلم عن الموفي كول. الموفي كول هو يعتبر ريلون شريك مصر تريتمنت فور كونستيبيشن. تمام؟ هو ساشيتس، عباره عن ساشيتس. الساشيت الواحد بيدوب في نص كوبايه ميه. المين كومبوننت بتاع الموفي كول هو بولي ايثيلين جلايكول بلس الكترولايتس صوديوم كلورايد، بوتاسيوم كلورايد، صوديوم بايكارب. ببساطه شديده هو الميكانيزم اوف اكشن بتاع الموفي كول ان البولي ايثيلين جلايكول بيوصل للكولون ان ابزورب، وبالتالي بيبدا بالايزو اوزموتيك بريشر ان هو يابزورب الووتر، وبالتالي بيساعد على الديفيكيشن والاكسكريشن بتاع الفيسز. طبعا ميزه الالكترولايت اللي موجوده في الموفي كول هو ان هو بيحمي من الكيدني ديسيزز او من الهاي بلاد بريشر او اي بروبلمز في الكاردياك بروبلمز. اشهر حاجه لاكسيتيف موجوده عندنا في مصر هو اللاكتيلوز. دي كومباريزون فيرسز اللاكتيلوز، ان البولي ايثيلين جلايكول بعد اول اسبوع ادى برسنتج اوف بيشنت ويز كليرد فيسز تقريبا دبل ريزلت اللاكتيلوز انيما، وفي ويك 2 كمان ادى تقريبا اولموست 90% كومبيرد ب 40% من اللاكتيلوز. ده بالاضافه لحضراتكم عارفين طبعا ان اللاكتيلوز مشهور بالسايد افكتس زي البلوتنج او الابدومينال بين او الفلاجلانس. دي ببساطه خالص هي الدوز بتاعت الموفي كول. 1 ساشيت بيدوب في ربع نص كوبايه ميه، بيتاخد من مره 3 مرات في اليوم. في حالات الفيكال انفكشن الموفي كول اولسو از ابروف. دوز 8 ساشيتس، بتدوب ال 8 ساشيتس دي في لتر ميه، والبيشنت بياخدها على 6 ساعات. البريكوشن الوحيد مع الموفي كول هو الهارت فيلير بيشنت، لان هو طبعا بيبقى سنسيتيف للصوديوم كلورايد، فبنقول ان هو ما بيتاخدش في 2 كيس اكتر من خلال ساعه واحده. اخر حاجه خالص ريليتد للبريجنسي، هو الموفي كول يعتبر سيف مع البريجننت، لان زي ما قلت في الاول البولي ايثيلين جلايكول هو نوت ابزوربد. فالحاله دي هم امريكان جاستروانترولوجي يعتبر كونسيدر سيف. اخيرا الاسعار بتاعت الموفي كول هو سعره 98 جنيه 20 ساشيتس، الساشيت الواحد 5 جنيه. بشكر حضراتكم، وزميلتي نور سريعا برضه هتعرف حضراتكم على البرودكت.
طيب انا بدعو الدكتوره ريم للقاء المحاضرتين. الاولى بعنوان تروماتيك كولوركر سيرجيكال اوبشنز فور disabling deformity، وفي المحاضره الثانيه ده اوبشنز فور تريتمنت اوف فيكال انكونتيننس. ومرحب بيا طبعا في مصر، اهلا وسهلا.
بسم الله الرحمن الرحيم. والصلاه والسلام على اشرف الانبياء والمرسلين سيدنا محمد وعلى اله وصحبه. First of all, I thank Dr. and Dr. Samir, everyone for inviting me. It's pleasure, and I'm very happy to see female as well. I'm not a feminist, by the way, but of course I'm happy to see a female in the surgery department. So I know you're not a colorectal, but I will try to make it as much fun and simple as much as I can. Before talking about cervical injury, I don't have disclosure. Sorry for the picture, but if you are a surgeon and you face this patient, what do you think? Who will treat her? Anyone? Who will treat this patient if she came to you with a fecal incontinence? Yeah. Yeah, but you will refer her to gynae or no? So gynae will be involved, right? You will think gynecologist at the first time, and that's pretty true. Because that cervical injury, usually these patients will not present to the doctor because there is no female. They are embarrassed to tell about their deformity. So one statistics that available is a colorectal surgeon gender statistics in the United States, and they found that the female is 41 in comparison to the male, which is 58, and that gap is decreased nowadays. But lack of female colorectal surgeon in the Middle East, specialized in the big floor, will leave the woman embarrassed and not ask for help. Another study was done to see the female authorship trend in the field of colorectal surgery. And they measured and they assumed that there is a female colorectal who will report and do a research in their field. And you can notice that the Middle East lacking of female colorectal surgeon. Overall, it's increasing in number, but worldwide, and still it's 26% in the world, only a female colorectal surgeon. So what are the barriers? Why female will not go into a colorectal surgery? Social norms, because not everyone will accept that they will go, a male will not accept going to a female surgeon, or even the female does not want a heavy workload. Discrimination, of course, in our society. Egypt is close to Saudi Arabia, I'm sure. And we know that we have that discrimination when it comes to the surgery. Work-life balance, till now, they ask me, who's going to do the surgery? And I hate that, by the way. And I'm proudly telling them, I am the one who's doing it. So lack of mentorship, it's very important. I remember when I chose a colorectal, at the beginning I decided to choose the breast endocrine just because it's easier, not because I love it. And I was loving colorectal, and I worked a lot in colorectal until my mentor told me, you love it, I think you are a candidate for colorectal surgery. So that's why I chose a colorectal surgery. Payment gap, it's not an issue in Saudi Arabia, I'm not sure here, but male and female get paid equally. Promotion inequality, usually whenever there is a promotion, they will promote a male rather than a female. That is worldwide. So in general, female underrepresented and not assumed a senior leading role. I was happy to be trained in Denmark at a specialized training center in pelvic floor and the colorectal, which is Aarhus University Hospital, with an amazing team specialized in pelvic floor disorder. So for cervical injury, a traumatic cervical usually resulted from major obstetric injury after 4-degree perineal tear, and usually it's a dimensional deformity from the perineal body, and then disruption of the anal sphincter and the loss of anovaginal or anorectal septum. It's very rare overall. Incidence, it's around 0.3% from complicated vaginal delivery, but whenever it happens, it is devastating. Usually where present, it's mostly functional abnormality. It will cause a severe incontinence to fluid, flatus, liquid, and solids too. Recurrent urinary tract or vaginal infection is another issue. Sexual dysfunction is significant usually, a majority will have dyspareunia or even refrain from sexual activity. Diagnosis usually by clinical examination. If you don't have the resources for any other investigation, you don't have to do the cloacal injury. Usually it's very obvious, but very critical and careful examination of the perineal body. As you can see, sometimes there is a bridge, but there is no sphincter muscle underneath it. Or a complete cloaca, whether the vagina open to the rectum and the loss of sphincter anteriorly. Examination, sometimes the perineum is intact, but this figure is called dovetail sign, when there is a skin only without underlying sphincter. As I said, it's not mandatory to do any other investigation, but if you have endorectal ultrasound, MRI, or even manometry, just to measure the muscle activity if there is anything. Pudendal nerve terminal motor latency, in Saudi Arabia we stopped it. It's usually painful and it does not add any added decision to the surgery. This is a picture of endorectal ultrasound. You can see the defect very clearly anteriorly, and it is sometimes for medico-legal issue. It's better to do an investigation. Assessment, you can do any other score for incontinence. There is Vasey or Wexner score, just to document the pre and post-surgical treatment incontinence score. Management, we will start by conservative. We have to take care of the skin, as the patient is usually incontinent. They will have a leakage of mucus or stool, so we have to protect it. I usually advise them for zinc oxide, a thick layer, 24/7 all the day. We have to manipulate the stool consistency. If it is liquid, we have to make it more solid in order to prevent the incontinence. Surgical management, different type of surgical technique. There is no documented in the literature one is better than the other, but I will just give you an example. Perineoplasty with exaflap. It's basically a flap that you can rotate it around the sphincter and close and prepare the perineum in layers. And that's the shape after layer to closure. This is wire healing, and this is the end result. The second is transverse to vertical incision. It's basically you open a horizontal and you close it vertical. Island flap perineoplasty is another way of doing it. The reported in the literature, it was usually done by stoma and fecal diversion, and usually that's the house of flap bilaterally, and the result was excellent. I will present a couple of cases that came to my clinic. The first one is a 19-year-old female. She came with 2 young children. She's medically free, presented with fecal incontinence in the last 5 years. She got married at the age of 14, and she got a 4th-degree perineal tear as she delivered a home delivery by herself. And she thought that the incontinence is normal after delivery, so that's why she did not seek any medical help. When she delivered in the second time, they saw her in the hospital and they told her that's absolutely abnormal. She presented with Wexner of 17, which is very high. And that was the picture. It's only a thin skin bridge in the perineum. BMI is she's very petite lady. BMI was only 18. I did MRI just to document the sphincter muscle, and you can notice that there is no anterior sphincter muscle whatsoever, which is 140 degree. So I planned for her perineoplasty, levatorplasty, and overlapping external sphincteroplasty with stoma. I diverged almost always these cases. Pre-op, I usually full bowel prep them, give them antibiotic, under general anesthesia. I do it in a broad jackknife position, urinary catheter, and stoma marking pre-op. The first step on the surgery is inspection, and then the incision usually horizontal. You have to keep in mind this filter, so go as much as lateral as you can. And then we have to dissect the anal sphincter muscle and then separate the levator ani muscle. When you see the fat on both sides, the ischiorictal fat, that you know that you are including all the levator ani muscle. And then you do a levatorplasty. The levatorplasty will work very excellent with the incontinence that they already have. So after that, application of the puborectalis muscle with the interrupted suture and the overlap sphincteroplasty if you can. If you can't, it's only approximation is fine. So, and then we will repair it in that shape. It looks ugly, but the most important is the function. So you will notice immediately that the anus will shrink and the vagina as well will close after good application of the puborectalis. And that was the picture during the healing, and that's the final result, completely normal perineum. And that was after 2.5 months. The second case is similar, a 55 years old female, gravida 3. She has a 13 years incontinence as well. She had a vaginal delivery, repaired at the time of delivery, but she developed infection, and after that it disease, and she did not seek any other help. You can notice that her BMI was 27, but you can notice also the defect in clinical. You can see that skin is flat, and that's a sign that there is no sphincter to hold the anus. Also, the MRI was a defect 150 degree. The plan was the same procedure, and that was the initial inspection during the OR, and that was after the repair. Patient lost a little bit follow-up. She came to me 3 months with a lot of granulation tissue, so I took her back to OR for over, just to clear the over-granulation. You can see that the anus is closed. That means that the overlap sphincteroplasty works very well. And that 1 month after removing of the granulation tissue, and that's the final healing after 4.5 months. So usually these patients are suffering with the dressing and the final surgery. I use two OBDS when I close the muscles, but the mucosa and the skin with 2O vitral. Most of usually patients will kept in the hospital only for 2 days. I prevent them from any vaginal or rectal insert for 6 to 8 weeks, and they can be discharged with a follow-up as a regular in 2 weeks' time. Important technical point during surgery: layered closure, mobilization as much as you can is very important, and try not to perforate the rectum or the vagina, and ideally it should be done by a specialized colorectal surgeon. So my conclusion in this lecture: traumatic cloacal injury following vaginal delivery is rare but devastating. Patients present not only with the fecal symptoms, but also that will negatively affect their quality of life and self-image. Surgical management is the mainstay and help to restore the anatomy and the function. And my final message, that I want to encourage every female to think about colorectal, especially the floor. It's okay. Any questions?
Yes, Father.
The problem usually if the patient is having forced degree perineal repair, do you prefer to repair it immediately or delay the repair? Because most of the gynecologists believe, no, just wait, leave everything healed and then repair it.
Yeah, this is the mistake. I'm always telling them, if you have a forced biliary repair, please, next day, book patient under GA and call me as a colorectal. And that's it. Immediate repair is the now gold standard and proven by literature that it will improve the function. It can heal very nicely if what was done immediately. I know the area will be traumatized, swollen, and there is a lot of hematoma, but under GA with proper positioning, you can repair it and can see the muscle very well.
if it did not present immediately, how long do you wait?
Yes. So if she did not present immediately, I will wait 6 months.
6 months.
6 months.
And what diet do you prescribe to the patient who stops low residue or high residue? Or you keep the patient empty over?
So it differs. This is a very important question. So sometimes, if you will ask for low residual diet, they will have a diarrhea. If you will ask for high, they will have a constipation, severe constipation. So in a patient who their bowel habit is diarrhea, you may think of, and they having an infection, you will think of stoma and diverting them up front. So each case has to be individualized. It's not a solid rule, but overall, if there is an infection, you will divert and then will wait till 6 months. I will not prepare it immediately. And the dieting, it depends. Sometimes I give a module just to prevent the diarrhea, and sometimes Movicol if they are constipated, and they can live with that easily. So I will talk a little bit about pelvic floor disorder. I'm still encouraging all the females to choose the pelvic floor. So I will try to make it as nice. I know a lot they will hate the pelvic floor, but I think it's a very important topic. So in general, who's the pelvic floor surgeon? A colorectal, a urogynecologist, or a gynecologist who's interested in pelvic floor. They can be specialized or according to their interest. So in general, pelvic floor dysfunction carry a lot of diseases, but I will try to define them as much as I can. It's a global, in general, it's a global problem affecting millions of women worldwide. But they think it's only for women, but actually men, they have a pelvic floor muscle. So men can have a pelvic floor dysfunction as well. So pelvic floor anatomy, you can know that the rectum is beside the prostate and bladder in men, and vagina and bladder also in women. So all these can be affected at the same time with pelvic floor diseases. The function, as we know, what is the function of pelvic floor? Pelvic organ support, bladder and bowel control, passing urine and feces basically, and sexual function, and breathing. Even for breathing, you are contracting your pelvic floor muscle without you know. Pregnancy and childbirth, one of the functions. What are the risk factors of pelvic floor dysfunction? Age by itself, you notice the majority of elderly, they will not have a full continence. Pregnancy and childbirth is the major risk factor in women. Genetics, sometimes you will see in the east, in the west, sorry, more pelvic organ prolapse than east. Pelvic floor injury in general, whether surgery or any trauma, or constipation, chronic strainer. This is the one of the major risk factors for pelvic floor dysfunction, and obesity as well. So it compromises a full range of diseases, as I said. If we would look into a Paris woman, that could be a sequelae of pregnancy. But men, what about men? So men, they can have prior surgical intervention, like prostatectomy, or connective tissue disorder. They have a neuromuscular disorder as well, or psychological, or behavioral problem, which is a very important topic. I will mention it. So basically, pelvic floor, I love that distribution. The first is urinary, which is overactive bladder or incontinence, urinary incontinence. That's considered as a pelvic floor disorder. Pelvic organ prolapse, if it is anterior, as a cystocele or the middle, uterine prolapse, and vaginal wens even, or vaginal laxity, posterior, which is rectal prolapse or rectocele. Anal incontinence, they can have it as a passive or urge, or obstructive defecation syndrome, which is another annoying, I would say, category of pelvic floor dysfunction, whether functional or anatomical, or chronic pelvic pain syndrome. The prevalence, we did a study, national study, in 30 regions in Saudi Arabia. We screened around 2,200 women. We found that the colorectal dysfunction around 50% of the women, with the majority is overactive bladder, which is 54. Pelvic floor can present with a low back pain. You will have a patient coming into the clinic, a typical scenario, I'm constipated, having hemorrhoid, I don't know why my back hurts. It's very common scenario to hear it in the clinic. So back pain can be a feature or even a symptoms for pelvic floor disorder. History usually, pelvic pain, pressure, patient will report a dragging sensation in the pelvic area or perineum. Urological, frequency, urgency, dysuria, bladder pain, etc. Dyspareunia, bulging from the vagina is another thing. Difficulty in passing stool. So not any patient telling you I'm constipated, it means constipation. Sometimes they will tell you I'm having anal blockage. There is nothing coming out. Straining. They will strain and they will tell you the stool is soft, but they cannot defecate. It will give you an idea that there is something with the pelvic floor. Fecal incontinence or leakage or seepage even. Our protrusion, any mass protrusion from anus. It's very important to ask about splinting, which is patient digitating through vagina or through the rectum in order to defecate. It's also a very common symptoms. And then pelvic pain as well. Physical examination, usually the inspection, as we said, to the perineal body and the anal sphincter. By manual examination, I usually do a vaginal examination in each patient if I suspected pelvic floor dysfunction. Digital rectal examination is not only introducing your finger. You have to ask for the squeezing and relaxation tone. And also, I used to do it at posterior traction of the pubirectalis. The majority of patients, if they present with a rectal pain, sometimes if you did not see a fissure in front of you, you have to raise a suspicion that there is something else other than, pelvic floor dysfunction or any other thing. If the muscle is a spasm or the pubirectalis, which is non-relaxing pubirectalis, you will have tenderness when you are retracting the pubirectalis. Sometimes you will do a cotton swab just to see the sensation, and sometimes also you have to examine the patient in the toilet, ask patient to protrude the mass. As a rule, if patient has a rectal prolapse, you have to see it before operating that patient. So that's why we ask patient to strain and we want to see it in front of ourselves. Evaluation manometry, if it is available, it's not available in majority of our hospitals as well, but if it is available, it gives you an idea about the functional status of the sphincter. Evaluation, as we said, electromyography, we are not doing it, but if it is available, it's painful. If it is available, also it can give you an idea of the muscle. A very simple test, which is the balloon expulsion test. In a patient who reported blockage or anal blockage, you can insert a balloon, special balloon, and ask patient to defecate. The majority, if they cannot expand the balloon, it can give you an idea that these patients having obstructive defecation. Endoanal ultrasound, just to assess the anal sphincter muscle. Difficography as well, it is best to rule out a muscle or even rectal prolapse. Dynamic MRI, the majority of hospitals now they are using dynamic MRI. The only thing which is annoying about the patient will lie on their side and we ask them to defecate. The majority they cannot defecate. Who will defecate while they are lying on their side? So it can give you a false idea about a false obstructive defecation symptoms. Treatment, as any patient, as a rule, you have to start with a lifestyle modification. If a patient has a diarrhea, you have to treat the diarrhea. If constipation, treat the constipation. Avoid alcohol. Caffeine can give a loose stool, so we will ask them to report it. In a patient who reports a lot of gases, Just if they are drinking a lot of cola 2-3 times a day, of course they will have a lot of gases. Acidic food, spicy food, artificial sweeteners, all these can have altered bowels, and cigarettes as well can affect your bowel habits. So weight loss, also I always advise them to lose weight. I know it's difficult, but 3 to 5% weight reduction will decrease the incontinence by 50%, only 5%. So I use to say to the patient, lose 5%, you will improve yourself by 50%. Kegel exercise can work, but Kegel alone will not work if there is a defect or a big defect. I use to refer patient to a physiotherapy to do a core exercises to strengthen overall the pelvic floor muscles. Medication, codeine sometimes can work in a patient with diarrhea or Imodium. Dilcolax, of course, constipation, or a bulking agent, as the Movicol, as they mention it, between, or even amitriptyline in a patient with a pelvic pain. So management depends on the cause, and we will mention it in a while. So biofeedback, a lot they think that the only treatment of pelvic floor disorder is biofeedback. It's not the only treatment. Even if you don't have a biofeedback, it's fine, because it's a complicated disease. You can do a physiotherapy, you can do other maneuvers and not to stop, because not a lot of centers have biofeedback. We have it only in 2 centers, and it's not even a well-structured unit. So it will improve the continence, relaxation, and a squeezing technique of the patient. So treatment, it depends on the underlying as a surgical treatment. So if a patient has a fecal incontinence and urinary incontinence, and they tried every other maneuver and it didn't work, so central nerve stimulation is another thing to consider. Urinary incontinence, which is mid-urethral sling, according to the underlying cystocele or whatever, and uterine prolapse as well. They will do hysterectomy, if that patient is elderly, and vaginal prolapse as well, and uricele and rectocele, and I will mention it in a while. So rectal prolapse, which is our specialty, if it is external, it's an easy. If it is external, you will repair it surgically, because it's not going to go or improve with any exercises. Pathophysiology, of course, increasing intra-abdominal pressure can recruit all the organ, whether the vagina or even rectum or bladder, and sometimes the small bowel, which is urethral. The grading usually is for research and can give you an idea which one will need the surgery. We have to differentiate, of course, between hemorrhoids and the full-thickness rectal prolapse. It's very common exam questions, whether this is a rectal prolapse or it's a prolapsing hemorrhoid. So that's another patient who's 80, presented with a hemorrhoid to the clinic, and pain and incontinence, because the majority with a full thickness prolapse, they could have an incontinence, but after examination, I saw the rectum protruding. So this is a full thickness rectal prolapse. Because she's 80 and she doesn't want a general anesthesia, I did her under spinal with ultimyoid procedure, which is perineal rectal sigmoidectomy. And that's after the resection. The preferred is lab suture rectopexy. Any young female who presented with a full thickness rectal prolapse, it's better to start with a laparoscopic suture rectopexy. I didn't do myself a vaginal mesh rectopexy because of the possible complication and erosion to the vagina. But patient can present with only as little as prolapse at this, which is anyone can assume that this is a hemorrhoid. I'm basically immobilizing the rectum and fixing it to the sacral promontory. Rectocele per se, I don't prefer to repair it because patient will come to you saying, I digitated through rectum to defecate. The stool is stuck. So I usually advise them to manipulate, take a bulk forming agent or any other laxative and see yourself and stop digitating as well. Sometimes it will work, and sometimes if it didn't work, even with a liquid stool, we can repair it. I personally, I don't use a star. I know it is reported as a good option for rectocele, but I use transperineal only repair of the rectocele and levatroplasty as well. The other thing is obstructive defecation syndrome. Remember, it's an iceberg syndrome. That means patient will present to you with hemorrhoid or constipation, but there is tons of other pathology. They can have a rectal prolapse, they can have a muscle issue, they can have a nerve issue, so we have to rule it out. So functional, which is the most common, they have a dyssynergia. Patients simply, while you are examining them, try to examine the rectal ring, not only the sphincter, and ask patient to squeeze. And when you ask them to relax, they will squeeze again, because their body suddenly started or decided not to relax while defecating. We don't know why, but that's what happened. So that's a dyssynergia. It should relax, but it does not. So that's why it will cause a constipation. Patient will spend hours in the toilet. I remember one patient, she told me, my husband flew from Dubai to Riyadh, which is 2 hours flight. He called me before going into the flight. And he came home, and I'm still in the toilet. So it tells you that there is something obstructing, there's something wrong with her during defecation. Sometimes it's behavioral or even psychological. So it's all under functional disorder. Anatomical, as a perineal hernia, pelvic organ prolapse, as we said, or solitary rectal ulcer syndrome, which is basically a form of internal intussusception. We have to differentiate as a surgeon between constipation and obstructive defecation. Constipation, in a simple way, it's infrequent defecation, less than once every 3 days, or passing a very hard stool, or both. But obstructive defecation is difficulty in evacuating or emptying the rectum. Patient will tell you the stool is soft, but I cannot defecate. So that's the actual definition of obstructive defecation, and spending more than 30 minutes in the toilet. It can be, as I said, due to prolapse or rectocele or anismus. MR bibliography it's very useful in diagnosing the prolapse. I'm not sure if the video will work. But during the MRI bibliography, you can see the muscle, which is the buccal here. It will not open. Usually during defecation, when we ask the patient to strain, it will relax. But this one, it will keep contracting all the time. So it can give you an idea about non-relaxing buccal. So management is starting by conservative, biofeedback, training, retraining the pelvic floor muscle to relax, and psychotherapy. I ask patients straightforward, do you have anxiety? Do you have depression? The majority, which is documented in the literature, 70% they will have an underlying personality or psychological issue. Sometimes if they don't want to go to psychiatry, I will start antidepressant in a low dose. If the pathology for obstructive defecation is buccal, we can even inject Botox through the buccal. It's not evidence-based, but sometimes it will work to relax the muscle. If it is other surgical, as a prolapse, we can repair it surgically. Anal incontinence, in short, whether passive or urge incontinence. So passive, it means internal anal sphincter pathology. Urge incontinence, usually the external sphincter, or proctitis, or rectal cancer. So it gives you an idea. We will do the score as I said, and the treatment usually local enema. It's very useful. I will ask patients because they don't want to use the phosphate enema for a long time, so I will tell them take the enema, put a warm water, and then use it if you cannot, or if you don't want to use any other method. Some patients will refuse surgery, so that's why it's basically a rectal irrigation or balloon retraining. Surgical, as we said, according to the underlying cause, if it is internal anal sphincter, you cannot repair the internal sphincter, so we can use injectables as a surgical option. External sphincter, I personally, if there is a defect, I will repair it. Sacral nerve stimulation if you don't have any other option or you have a urinary incontinence. Stoma is the last resort of everything else did not work. That's the second nerve. So just a few words for chronic pain syndrome. It's usually underdiagnosed because we use, as a surgeon, we love to see something and we fear that that's the reason of your pain. Hemorrhoid does not cause pain. So please, it's almost never causing pain unless it is thrombosed. So if you did not see a thrombosed hemorrhoid in front of you, the pain it's not from the hemorrhoid. There's something else. If it is not a fissure or a thrombosed hemorrhoid, and patient will have they're screaming with pain. I'm talking about the severe pain, not the pain because the hemorrhoid is engorged. Because the engorgement of hemorrhoid can give a discomfort rather than actual genuine pain. So sometimes patient will report a brief pain that lasts for a few minutes, less than 30 minutes, and will go by itself. That's what we call it proctalgia fugax. And I wrote it in Arabic because it's very important to unify our terminology and tell the patient that there is a diagnosis and there is a name for your condition. Patient will feel happy that they know what's wrong with them, which is ألم المستقيم العابر. So elevator anal syndrome, you will hear a physician telling that this is a non-relaxing puberectalis. It's almost the same, which is ألم رافعة الشرج or متلازمة العانة. And usually it's very severe pain, lasts for more than 30 minutes, may be triggered by defecation, so that's why we would think that there is a fissure that we cannot see it. Usually the fissure, you will see it. So if it is fissure, you will see it. If no fissure, there's something else. Or unspecified functional pain after we rule out every other thing. The very important thing in elevator anal syndrome, if you examine, as I said, there is a tenderness when you are with the posterior traction of the puberectalis, because it's basically muscle spasm. And coccydynia is another very important pain. Patient will present to you with a rectal pain, but actually there is nothing in the rectum. It's tenderness when you palpate the coccyx from inside or from outside. Pudendal neuralgia also will give a pain. The female patient will say, I have it up to the vagina. Male will have it to the penis or scrotum. They will report a post-sexual intercourse pain or post-even erection pain. And the majority it's pudendal neuralgia. The difference, pudendal neuralgia, usually it's in one side rather than bilateral. It's very unusual to have it bilateral. The treatment, for the majority, it's medical. Unless for levator, I used to inject botox. I'm not sure if it's psychological or not, the patient will improve after that. But the most important is digital massage. Patient will visit every month once, and you have to relax the muscle by doing BR and massaging both sides of the coccyx. Biofeedback will work in the majority of them. And then since I usually give them amitriptyline, 10 milligram bedtime. Patients will love it. It starts working after 3 weeks and will improve. The pain usually will improve. For coccydynia, I inject a steroid over the coccyx, and usually it's immediate cessation of pain. We started our pelvic floor unit in our hospital. There is, unfortunately, in Saudi Arabia, no dedicated pelvic floor unit till now, and I'm trying my best to recruit all the urologists, urogynecologists, radiologists interested in pelvic floor, clinical nurse who is a specialist in colorectal and urogynecology as well, and a specialist continent nurse. You have to have a pelvic health physiotherapist. We're lucky to have two, but we don't have a male physiotherapist. It's good to have a research scientist as well with you. Investigation, I think that mandatory to have manometry, endorectal ultrasound, MRI difficography, conventional difficography for research purposes and for diagnostic. SITS mark also for functional constipation or to rule it out, advanced colonoscopy and sacral nerve stimulation, injectables as sphincter keeper, which is basically injectable for the internal sphincter. I used nowadays fat injection for Crohn's fistula, and rectal irrigation as incontinence, bowel incontinence product in general, which is anal blood basically. The female usually, I mean, if she's afraid from doing surgery, she can live with that. Biofeedback. We translated a lot of leaflets for patients. Patient education is very important in pelvic floor. And research as a tissue bank and database. So in conclusion, pelvic floor disorder should be managed in a multidisciplinary team. Pelvic floor, in pelvic floor, patient education is the most important. And the good news is that many patients will improve in their symptoms and their diseases is treatable. Thank you very much.
شكرا جزيلا للمحاضرتين المبدعتين دول، ولو في اي اسئله
تورينا الحقيقه ان احنا هنا في مصر الميل بيشنتس young male patients who are having obstructive defecation are a lot. يعني maybe as equal as female. يعني الحقيقه ان احنا الدكتور احمد كان اشتغل على الموضوع ده زمان. young male patients who are having obstructive defecation. دي مشكله بتواجهنا اكتر. Psychological problems are really happening. كلنا بنهرب من الحالات. All of us are.
I think that's what I'm saying. The majority point could be whenever they have a patient constipation and they suspect a psychological issue, go to him. She is the best. I know. I spent 45 minutes taking history and investigating, just ruling in or out the obstructive defecation. The only problem that they don't know how to defecate, and suddenly they use, while they are children, to have a constipation, and then during the puberty, they don't know how to defecate. And they are embarrassed to talk about it. And they don't know it is abnormal, unless they are 19, 20, and then you will have another peak around the 50s. So the 30s, it's very unusual to see it. It's usually whether 19, 20, 25, this age, and then the 50s. That's the peak that I'm seeing.
Actually, one thing I noticed that a lot of these patients, when I study blood numbers, a lot of these patients are having rectal hypersensitivity.
Yeah.
And nobody's recognizing that they're having rectal hypersensitivity.
Yes. Yeah. They will say, I don't feel the urge to go. I will spend 7 to 10 days. One patient following with me, he was 29 years old. He's unemployed, did not went to anyone because of incontinence. And basically, unfortunately, I did not put the image. When I take a picture, it's basically the abdomen is a rectum, mega rectum, with a full of fecaloma. And basically, it was an overflow incontinence. And I admitted him. I used all the residents to do our manual disinfection, just to know how it should be done. So manual disinfection, very strict, I will say, laxative protocol. And then I repeated the imaging till it was empty. We gave him
الفيميلات. احنا سعداء بوجودك معانا. الحقيقه يعني احنا بنستمتع بوجود الفيميل كولوريكتال سيرجنز، واحنا عندنا يعني جود نمبر الفيميل كولوريكتال سيرجنز. وفي مصر كان في اول كولوريكتال سيرجن كانت الدكتوره ألفت السباعي، كانت رئيسه قسم الكولوريكتال سيرجن في جامعه المنوفيه. بدات الكارير بتاعها في السبعينات. لما بدانا نروح الامريكان سوسايتي كولوريكتال سيرجن في التسعينات كان عدد الفيميل كولوريكتال سيرجن كان قليل جدا، وكان اعظمهم طبعا ايدي نيلسون كان على قمه الميو كلينيك. فطبعا وجود الفيميل كولوريكتال سيرجن دي حاجه ممتعه في التخصص، واحنا بنستمتع بصحبتكم في التخصص بتاعنا. نيجي بقى لتعليق بسيط في كلواكا ريبير. هل حضرتك لازم تعملي ستوما في كل الحالات؟
I do believe that the first repair is the best option. So I will always give a patient the option that the best, in my opinion, to do a stoma. I did it, to be honest, twice without a stoma. It went very well. But still, if a patient has a higher BMI or diabetes, I'm not risking it. So if she is a comorbid, I will give her a stoma for sure.
Okay.
But if she is, medically free, young, normal BMI, I could give her an option without a stoma. Because eventually they will heal.
يعني انا يعني دعوه من اخ اكبر ان انت ما تعمليش ستوما في الحالات ديت، لان احنا بنصنع بودي ايمج ونبوظ بودي ايمج تاني. فيعني هي هتمشي كويس من غير ستوما ان شاء الله باذن الله. فدي من خبره عبر السنين ان بنعمل الحالات دي من غير ستوما وبتمشي كويس جدا يعني، ومن احسن العمليات في الكولوريكتال سيرجري في النتائج يعني كسفنكتروبلاستي. الانتيريور سفنكتروبلاستي احسن من البوستيريور واحسن من اللاترال سفنكتروبلاستي، والكلوكال انجري دي بتدي نتائج كويسه جدا. فشكرا على مجهودك وشكرا على ان انت بداتي سكه الكولوريكتال سيرجري في المملكه السعوديه الشقيقه، وان شاء الله نتشرف بوجودك تكرار ومرار ان شاء الله.
مين الجيل الثاني من كولوريكتال سيرجري؟ في جيل قبل كده؟
لا طبعا هو في
ميل تو
في تحسين.
لا احنا بنتكلم على كان بدايه سنه كام؟
لا هي اول وحده احنا دكتوره سمر.
دكتوره سمر يعني ترند في سان مارك في 90s. لا مش في 90s.
ايوه وبعدين ما في كولوريكتال تل واحده قبل بسنه وانا وبعدين تحتنا 8.
احنا عندنا بعد كده مفيش ميل خلاص.
السلام عليكم دكتور وليد. اهلا بك في مصر وبرحب بحضرتك. كان سؤال اوت اوف سكوب من المحاضرات بتاعت حضرتك، واستغل وجود الدكتور احمد حسين والدكتور خالد. لو حاله ياتروجينيك ريكتو فاجينا فيسكولا بعد كلوجر القطن، البيست تايم للريبير بتاعها هيبقى امتى والابروتش بتاعها؟
ياتروجينيك ريكتو فاجينا
يعني بعد ما قفلنا بالدباسه السيركولار العيانه ديفلوب بوست اوبرتيف ريكتو فاجينا فيسكولا. غالبا جزء من الفاجينا كان وزين الكف بتاع السيركولار ستيب.
يعني يعني انت خدت ستيبلر وانت يو انفولف الفاجينا انسايد.
هي العيانه كانت عامله بوست هيستريكتومي، فكان في جزء من الفاجينا اوريدي لازق في الستامب بتاع.
يعني قصدي ان هي دلوقتي this is a stable system.
بالظبط.
يعني I will wait for 6 months before I try to interfere. مش هنترفير خالص.
لا بالعكس بس هي الفكره انا عايز اعرف الليفل بتاع الريكتو فاجينا فيستولا فين، هي لو انترميديت ولا هاي؟ يعني هي على بعد كام سنتي من
6 سم.
يعني انترميديت؟ فدي مش هينفع فيها موشس لا من تحت، دي عايزه دوبلر ريبير.
والتايمنج بتاع الريبير
6 مونثs ده بقى لك الدكتور خالد، يعني لحد التيشو ما تهدى خالص، وبعد كده ممكن نحط انترفيرنج بقى لازم يا اما اومنتم يا اما كراسيبس من تحت.
احنا بنشكر.
هو 6 month magic time.
طيب يعني احنا بنشكر حضرتك انك شرفتونا في اسكندريه والمحاضرات الجميله دي وان شاء الله تتكرر تاني. شكرا جزيلا. هناك صوره جميله.